we are going to now turn to community-based opportunities, and we're going to hear about some experiences in Detroit and Tennessee. First of all, we're going to hear from Deborah Sundal. She's the Vice President of Strategic Solutions at United Healthcare Center for Health Reform and Modernization. In that position, she develops and implements original clinical interventions and new approaches to care delivery. These address chronic conditions and consumer access to health care. She's an industry product and operations expert with significant experience developing and implementing behavioral change products and services. Her group develops and tests projects aimed at improving consumer activation and health outcomes based on medical evidence, bringing them to scale, and then making them accessible and affordable. She has a master's from the University of Minnesota and a BA from Luther College, and I'd like to welcome her to speak to us.
Great. Good morning. I'll actually start with a personal story. 14 years ago in May, I remember being in the hospital and holding my newborn baby and feeling a bit relieved that I had successfully prepared for the birth of my child. And then it dawned on me as my husband and I were driving home that I had spent more time preparing for the birth of my child than I had for caring for that baby in the first weeks and months. Which then became a scary proposition when the first nurse visit came and I received a label of that my baby was failure to thrive. And if it wouldn't have been for the support of lactation consultants and my family, at that point I probably would have given up breastfeeding. But I didn't, because I did have that type of support. Now that was 14 years ago, and a seed that was planted in me, and my work and those personal experiences have come together. So today I'm here to tell you a little bit about what our group does within United Health Group. So United Health Group is the umbrella company to two different companies. One is United Healthcare, which I'm sure many of you are aware of, which provides the payment structures, and then Optum Health, which is a service delivery. So we sit in the umbrella company, and what we do is we focus on transformational innovation. And the vast majority of my work is actually working with other leading industry partners, researchers, as well as nonprofits, to say what new evidence-based practices are available, and how can we help use or help scale, national scale of those assets that would benefit the health and well-being of families and people across the United States as well as worldwide. So we need transformation, and we look at this every day. We look at it from a policy perspective, we look at it from a health outcomes perspective, we look at it from a data perspective. And today, as our group does this, we're really focused on these top four boxes. So one is what we're all keenly aware of is the relentless cost growth of healthcare. We look at also care delivery, and that's what I'm here to talk to you about, is how do we enhance and improve care delivery and be a part of that solution. In addition, part of that efficacy of people, of how do we help people more easily engage in their own health, in addition to access. So that is what we are doing within this small think tank within United Health Group, and it is a pleasure today to tell you about one particular project that started in 2012 with Yale University, Vanderbilt University, and many other provider practices in Detroit and Tennessee. The model is called Expect With Me, and what it is a new group prenatal care model. And And that's what I'll spend the day telling you about. One of the reasons why our group is so particularly interested in it is for the bullets here below, specifically around how do we look at and how to payment and silos of care. How do we use technology? United Health Group actually happens to be one of the largest non-technology technology companies. So we have massive assets of how do we bring technology to scale, especially in the health industry. In addition is you can build programs, but one of the biggest challenges that we see is how do we help the community engage in those, not with a stick, but with a carrot, and bringing them something that is elegant, that is desirable, and has a consumer product feel, something that people want. And I think that that's a big part of this whole program of Expect With Me, and I'll show you what that means. Also, we have incredible access to data, and that is where we started. We said we were looking at prenatal care and looking at birth outcomes in the United States, and we'll show you some of the data that we've seen in our own data sets, but I'm sure you are all keenly aware of too, with regards to birth outcomes and prematurity. And then finally, we do know that plenty of research shows that at the time of prenatal care is oftentimes the first time that people are truly engaged in the health system. And so we looked at this as an incredible opportunity. We've done significant work in diabetes prevention, childhood obesity, and we kept moving the needle back, saying, let's start this earlier. Let's start this conversation and dialogue. And there's also a much more an openness to change when you're doing something not only for yourself, but for the health and well-being of your children. So that is why we started this project in 2012. And so today, as we go through this, I'm going to show you some videos on how do we talk to moms about this care. We'll tell you why what are the initial data sets, and then we'll most importantly tell you about our scale plans and how we are partnering with large nonprofit and academic partners to bring this to national scale. And I think one thing that's really important is we are not bringing this to national scale for United Healthcare members. We believe that this program and care model needs to be brought to national scale and international scale for anyone, regardless of insurance carrier. And so part of what our role will be is once we have a sustainable model, is we will then begin to partner with additional insurance companies to really bring this model forward. And that's a big part of what we do is collaboration across industry. So here are the numbers you probably already know, and but this is what this analysis is what got us started. So just the rates of prematurity and the incredible costs associated with that. And I will stress that the first cost is the human cost, the stress on the parents, the stress on the babies, but there's also a financial cost. And so when you look at within the United States alone, $26 billion of our is spent annually on preterm births, and that's $51,000, dollars per baby. In addition, there's massive racial and ethnic disparities in the United States, and we think that that's wrong, and we have an opportunity to change that. So when you look at the U.S. rates compared to our neighbors to the south and our neighbors to the north, our outcomes are significantly worse. And when you compare that to the worldwide population in the U.S., those outcomes are also significantly worse. And so we are 130th out of 184 nations in our birth outcomes. And that's just the birth outcomes. I think what's also important to note is that the practices that are established within those in the prenatal time and in that first year of life are practices that predict the trajectory of health for a lifelong journey. So our hope in this is not just to save lives in that at birth, but also to change the trajectory of health long term. So, in 2012, we met a great researcher from Yale University by the name of Jeanette Ikovich, and we together started talking about, well, if we were to build this consortium and if we were to build this partnership, what would we do? And what would our goal be? And it came back to the triple aim. And so our goal at day one, before there was a pen on a piece of paper saying, what does this model look like, was to meet the triple aim. And to meet the triple aim, but to also nationally scale this model. And I think that that's important. You can have a highly effective program that sits on the shelf and never gets disseminated. It affects no health. A prime example of that is the diabetes prevention program that was researched. Had it been a drug, it would have been flying off the shelves. Millions and millions of our federal dollars spent on that research. But it took a partnership between United Health Group and many, many others, spearheaded by the CDC, to really start the scale of that. We had that as our model, and we said we can do this in prenatal care as well. So we want to enhance care, we want to improve outcomes, we want to reduce costs. But the other piece of this is we want to change the trajectory of health for families. So here's where we've been. And I was asked several years ago to speak on this topic, and I said, just give us a little more time. I want to be able to show you some of the great outcomes and some of the pieces that we do. So Carla has been very, very patient with me as we've been developing and now studying this model. So the original research on group prenatal care was done by Yale and before 2012, and there's a lot of good evidence on why group prenatal care is effective and how it's effective. Then what we did is in the end of 2012, we started to build the model, and we said, well, what does this model need to look like? What is important is this is not care augmentation. This is prenatal care. It is changing how prenatal care is delivered so that important topics like breastfeeding can be fit within the care model, not sitting outside. So we developed that with Yale, United Health Group, and Vanderbilt. And then we launched a full IRB-approved study that is being run by Yale, and that is going on today in Nashville, Tennessee, as well as in Detroit, Michigan. And we're excited that we're getting, we almost have 500 participants enrolled in that study. And what we are doing is ensuring that the efficacy of this new model is, in fact, matches a lot of the journal outcomes that have been previously published. So while the study, Yale is charging ahead on the study, what we are now doing is we are looking at the model, which includes many different components, and enhancing it and saying we have the medical care of this right. How do we now build an additional circle outside on the outside of that ensures scalability? How do we help reduce costs for clinics to implement this? What are technologies that can be brought to this model, and how do we talk to moms so that they know that this is better care, more elegant care, and a simpler way to receive prenatal care? So we are doing that now with another national leader in the nonprofit space, as well as Yale. And the whole goal is we won't stop until we have received national scalability, and we are also looking at international as well. So this is an eye chart, and what I'm going to quickly do is actually go to a video that tells the moms what this care is. But I wanted to start with this because it's important. When you see the videos and the content, one person said to me, "Deb, it looks really slick," and the marketing aspects of this are important because moms need to know and need to quickly understand what this care is, and that it is more elegant, and that there's benefits for them, not just for their baby, but also for them. But that's not where we started. Where we always start are with the national guidelines and with evidence-based practice. Nothing in United Healthcare in the same regard of regulation, nothing will be covered unless it starts with the evidence. And we believe that it's our group's responsibility to help spur that on and make that a faster process. So first we started with ACOG. We did not create our own medical standards for what this care will be. We went to ACOG and the American College of Nurse Midwives and ensured that we had a one-to-one match with what their recommendations are. And you can go down and see it's 10 two-hour sessions, etc. And we built an evidence-based model. But what we're going to do now is we'll flip to a video that shows you how do we talk to moms about this? How do we invite them to participate? So we'll flip over to that first video.
Hello, Mommy to Be. I'm Janelle, your been there, done that mother of three. Thank you very much. And yes, your Expect With Me pregnancy cheerleader and virtual BFF. Knowledge is power. So here's what I want you to do. Join Expect With Me to gain the skills and support needed for a healthy pregnancy, healthy family, and healthy future. I don't know about you, but when I go to the doctor, here's how it goes down. I wait, and I wait, and I wait some more, only to spend 10 minutes with my provider. What's up with that? Now imagine blowing past the waiting room and getting 2 hours of your provider's time every visit. And then imagine learning with and from other women whose babies are due in the same month as yours. That's exactly what you'll get and Expect With Me. It's like one-stop shopping. You'll schedule all your appointments with your provider, you'll get your lab work done, and learn about nutrition, exercise, labor and delivery, all in one place, instead of running around all over town. So why choose Expect With Me? You get more time with your provider, you get more knowledge, and this kind of group prenatal care lowers the risk of having a premature baby. Plus, moms are healthier, especially when it comes to delivery, breastfeeding, and future pregnancies. Let me sum that up. It's better for you and your baby. Learn more about Expect With Me today and call now. I cannot wait to see you again. You calling, right? Okay.
All right, we'll get back to the slides. So that has been used to recruit study participants, and yes, they go through all of the study protocol as well, but they come in having a clear understanding of what they'll be receiving. So the model that we built focuses first and foremost on prenatal care, and that's what we just spoke about. But there's also additional pieces that will enable the scale of this, which include technology. So one of the things that we know is oftentimes in a care setting, even if it's a longer care setting, there's lots of good information exchanged, but you go home and you scratch your head and you say, what was that? And so each participant receives a login to a website that we'll show you in just a minute that has access to care, to videos, to tip sheets, and even to a discussion board with the other women that they are experiencing care with. And that's really important because in essence that technology is enabling more care, more access to care and more continuity. It also, with that social connection, encourages people to come back to their care sessions. In addition, the marketing tools of one of this is how do you describe what group prenatal care is. And so we're spending a lot of time with the physician practices on how do you describe what this is, all the way down to how do you schedule for it, which is, interestingly enough, one of the barriers for practices moving into group care because it's a different scheduling system. In addition, we're just looking at the overall sustainability. So there are many, many groups, practice groups that have started group prenatal care, but because it's such a different way of delivering care over time, go back to the more traditional model of one-on-one. And so we're looking at, once practices start, how do we encourage and how do we help support the sustainability with practices that have started. So what I wanted to call out here is there are 10 care sessions, and breastfeeding is a key component. As we built the model and the curriculum, we built it in a cyclical way. Not that you're introducing and talking about a subject once, but multiple times. And so we, very early on in the third care session, which is at 21 to 24 weeks, we introduced the primary topic is breastfeeding. And what that is not how do I breastfeed, but why? And how do I talk about it with my partner? How do I talk about it with my mom if she didn't do that? And I think what's really important in these care sessions is what ends up happening is it's not the provider who is so much talking about that. It is the group. So where they are sharing their own stories. And some moms have had previous children, some moms are first-time moms, and that community sharing that says, here's how I addressed it. And we wanted that conversation to start very early so that it wasn't at the time of birth where they are contemplating whether or not they will breastfeed, that it's a decision that they're making early. We even have a pledge card of that commitment to breastfeeding. And then we come back again. And so in care session 9, which is at 35 to 39 weeks, then we talk more about how to do it. And the theme continues to go through each one of the care sessions. In addition, with the clinic commitment, this is a major change in practice. To deliver group care is a major change in practice. And so what we want to do is ensure that we're enabling. The best is an opt-out model, where this is the way that they give their prenatal care. And what we have found, and what other groups have found who've been doing prenatal care for a long time, is that the best practices are those that are 250 deliveries a year, and that there's at least 6 OBs. And one thing too, there's a bit of a prejudice that group care is a midwife-only model. And one of the pieces that we wanted to bring to this is we do believe that midwives deliver this beautifully. But to really have an impact, we believe that this is how all care should be delivered, and so that it is not a midwife-only program. In addition, the clinical infrastructure, the costs, addressing all of those pieces, as well as leadership support to support this type of change in practice. So here's the website. This is the introduction, and it's a calling card to start. So it describes it. There's access to that video on the website, and what you'll see in the upper corner is a login page, and that's where people then can, once they are enrolled, they can access their information from their provider. They can access information from the women with whom they're experiencing group. And so here's what it looks like. And we worked long and hard on this, and it has a bit of a Facebook feel. But what you'll see down on the left-hand side is the dashboard. It gives information on the sessions, where to go, and the address, etc., because sometimes logistics are the hardest part of receiving prenatal care. In addition, a discussion board where moms can discuss with each other, and on a weekly basis, there's an automated, the physician and the practice approves for that message to go out, but it reinforces and creates a dialogue on what they covered in the last care session, so that is instilling, as well as a journal, which can be made public and can be made private. So they're journaling throughout their pregnancy, all the way down to my group and my daily health chart. So there's a lot of information where you can, that you can access. In addition, some healthy behaviors and trackers throughout the pregnancy, which include nutrition, physical activity, prenatal vitamins, and dental health. So all, again, based on the evidence of what's important during the pregnancy. So they can access, and what I pulled here are two, but there's many, many tip sheets. And these are great tools not only for the moms, but also for the partners of the moms. So in most group prenatal care sessions, the partners, which can be a spouse, it can be the father of the baby, it can be a mother, it can be a friend who comes with them and engages in the care as well. And so we have many, many, many of these, but they're great tools that then they can bring home with them, access via their mobile phone, and reinforces what's being discussed within group. And I do have copies of these. If you want to read some of these, I have that I can happy to share with you. So Janelle is actually, she's an actress in LA, and so you might have recognized her from some commercials, but she is a mom, and a mom of 3, and we were so thrilled to find her. And so one of the pieces that we knew and that we heard from practices, it's really hard to have a conversation about breastfeeding. It's really hard to have a conversation about safe sex and sex during pregnancy or after. And so one of the pieces is we didn't want for those conversations to go unhad, because they're so important in the health and the longevity of both before birth but also after. So we created these short videos, and what we'll do next is I'll show you the video on breastfeeding. And the providers can show this during the care session and then have a dialogue about it. And this does 2 things. 1, it invites a conversation that's sometimes difficult to have. And 2, it ensures that we're aligning what is being talked about back to the evidence. So again, these are fun and informative, but I think what you will find is that they are also steeped in what we know is best practice. So we'll flip now to the breastfeeding video just so you can see what that looks like.
Janelle here, urging you to breastfeed because the benefits for both you and your baby are extraordinary. Breast milk is the perfect food because it has all the nutrients your baby needs to grow healthy and strong. In fact, you should feed your baby only breast milk for the first 6 months and keep breastfeeding for at least another 6 months as you introduce solid foods. Hey, breastfeeding is a win-win! Here's what your baby can look forward to. Liquid gold, that precious string called colostrum that your body produces right after your baby is born. A strong immune system. Breast milk helps keep your baby from getting sick and decreases the risk of asthma, allergies, and obesity. But that's not all. You will reap the rewards as well because breastfeeding is virtually free. You're already stocked and it's always the right temperature. Breastfeeding burns about 500 calories per day and could help you lose weight faster. And long-term breastfeeding reduces the risk of breast cancer. And now, the big bonus prize! More beautiful bonding time between you and your baby. Woo-hoo! 3 things to keep in mind. 1, if your milk doesn't come in right away, relax. It may take a few days. 2, the more you breastfeed, the more milk you will produce. And 3, your baby was born with the instinct to nurse. So pull that little darling close because it's all about getting a good latch. And no, I am not going to show you. Even with all these things in place, it may not be smooth sailing, so don't be shy about asking for help. You and your baby, you can do this. See you the next time. Give me that mic.
We love Janelle. All right, we can go back. So I'll stop here. As you can see, this type of work does not get done with United Health Group alone, or Yale University alone, or practices alone. It's a collaboration, and I will say that collaboration has been an incredible journey, and we believe we're just at the beginning of it. So where we are now is we have 2 study sites. So Vanderbilt is leading the study in Nashville, and Doctors Hospital of Renaissance we were working with Doctors Hospital of Renaissance in Texas for a while, and they're very interested of moving forward in the near future. But then in Detroit, we also are working with some key hospitals there. And so it is a journey, and our goal in this national scale and what we've learned is it's better to start with key locations. And so what we are doing now is we're building on the non-study components for national scale as we're scaling to more hospitals and more practice delivery sites within those communities, so that we can truly get centers of excellence who become proponents of this as well. We are talking to several other states in addition, and our goal is within the next year that we will hopefully be within 4 states, and then we'll continue to move out from there. So the good part about this is that this is not a business. This is a mission. And our goal is to bring this model forward. It is accessible, and anyone who's interested in helping spur on and bring forward this model, we are thrilled. And what our role within United Health Group will be is, we always say that we work ourselves out of jobs. And so our goal and our mission in this has been to help be the Kickstarter, to bring the collaboration, to bring the groups together. And we are now at a point where many other organizations are being invited to help with the national scale of this. And so we have a passion for the development of models that are both evidence-based but also engaging for patients, and engaging for practices, and reduce practice burden. And that requires an army. And so I hope that when I come back in a year or 2, that this map continues to fill, and potentially even we can scale this internationally as well, which is a mission of our company as well. So I thank you for the opportunity to speak, and I appreciate it.
So we've got some folks with questions. Great.
Casey from the University of Rochester. Is this still not?
Is it not on?
I can talk really loudly. Casey from the University of Rochester. So I'm going to ask the obvious question, which is centering pregnancy.
Mm-hmm.
And it seems like one of the major differences is, I'll talk quieter now, is the online stuff. Mm-hmm. and the engagement piece. Mm-hmm. Are there other key differences that you'd like to point out for your model?
Yeah, and we have worked closely with Sharon Rising and others, and so that was one of the questions is, do we need another group prenatal care model? And so one of the big pieces is, as we were launching this in 2012 and having that dialogue with them, we were ready to really start building out the IT infrastructure and the engagement model. The third piece that I would say is data collection. So within this, this tool, a key differentiator is, as moms are using this and as practices are using the online tool, at the same time we're able to collect a lot of data and really be able to watch not just the outcomes of the model, but also the engagement pieces. At what time do we start to lose participation, because we know that participation is a direct driver, participation in their care is a direct driver of some of those outcomes, especially around breastfeeding, et cetera. So it does data collection, it does technology, you're right, for both practices and for patients. It extends the care model outside of the face-to-face time, and it really starts to invite women in a in a new way to participate in this type of care. Now, with that being said, we strongly respect, and we believe that there's room for many models of group prenatal care. We have built one, and I am sure that there will be others. And yes, we are grateful for the evidence base that that Centering Pregnancy has given, and we based a lot of our decision to go into this kind of care based on their outcomes in the Green Journal.
Thank you.
Do you want me to, sure. Do you want me to start? I think mine's quick. Kelly Scanlon, CDC. My first question was the obvious question about centering pregnancy, which you've answered. My second was, you talked about scale up, but I wondered, are there any plans for scale up to move to a model for what centering does as centering parenting, but the group care for the first year? And all the issues that come up around feeding and complementary feeding and nutrients.
Yeah, definitely. It has been in our discussion. We have not started building that model yet. But what I will say is our team within United Health Group, we started with working with the CDC and working on group, or excuse me, my mind is in group prenatal care, working on diabetes prevention. So within that model, so with adults, we did the national scale of the diabetes prevention program, and then also created a virtual experience of that, which had similar outcomes in the publication. We moved back and we said, what about childhood obesity and what can we do? So we created a model called Join for Me, which would be an incredible, when you think about nutrition, et cetera, it's a parent-child model. And so that is available in states, and that it has an evidence-based and publication about, behind it. We then went to prenatal care, and so there's this obvious little, how do we get a full continuum?
Exactly.
And so yes, we first want to get this one right and get this on its way, and then what we do is, as others are partnering with us to scale it, then we can start to move into some of those other spaces.
Okay, thanks.
Hi, Ann Bartholomew, USDA Food and Nutrition Service.
Yeah.
I was wondering, in your 2 pilot areas, the percent of women enrolled that are considered low income or even Medicaid eligible?
Yeah, so one of the pieces is that this is not a Medicaid-only program, and it never will be. We have, I would say that Vanderbilt, it is about 50-50 of private insurance versus public insurance, and because and then in inner city Detroit, it sways more towards the public insurance, but again, we are not targeting this as a single type of insurance. We believe that all women benefit from this type of care, and one of the pieces that we've seen at Vanderbilt is, just human stories that are incredible, and I can, and we even have some quotes from moms and quotes from providers of when you group women and families together in a similar situation of pregnancy, socioeconomic and demographics do not matter, and we think that the group care is best delivered in a practice where all women are of the same gestational age and shouldn't be dependent on what type of insurance they carry.
Thank you. I was interested also in when you do publish, to see if there's any differences in what happens with the different income stratas.
That is published, and so Jeanette Ikovich has that in her initial research, and what we see is that the biggest benefits are for lower income because they have less access to food, nutrition, etc. So we definitely see that there is disparities between birth outcomes, and we do see that the biggest benefit is in lower income women. But there's benefits for all.
I'm Isadora Hare, recently retired from the Maternal and Child Health Bureau, now a consultant, and I actually identify with the previous questions that people have given you. I congratulate you on the model. It seems very exciting and very promising. And of course, you cover a wide range of topics. But I wondered if you also cover some mental health issues like depression and anxiety, previous traumas, etc., and how this affects the woman's experience of pregnancy and delivery.
Mm-hmm. I think what is important, so we have been talking about that more. When you look at the care sessions, you can see where that is woven in. Specifically, we talk about postpartum depression, but there's two ways I'd like to answer this. First off, it is important, sometimes some practices have high exclusionary criteria of which women can participate in group prenatal care. We believe, and in working with a lot of practices, what we've seen is that the best is that it is an opt-out model and that there are almost zero, there is close to zero exclusionary. And so one of the pieces as practices have been scaling this is, do we screen out women who suffer with mental health issues? And we believe that the answer is no, unless it creates high anxiety for them. And so with this, I think what's really interesting is when you look at the framework for what gets covered in each of the 10 care sessions, that is a framework. It is not a curriculum. And so the nature of that group, when we start to hear the stories of the discussions, so whether or not you're having a conversation about safe sex or sexually transmitted diseases, things that typically are not coming up in regular prenatal care, breastfeeding, or biases towards breastfeeding, it is the group that engages that conversation. And so if it is a concern of the group, then it becomes the topic of discussion, and there are support tools to support that dialogue. So so we can show you once again, and I can show you afterwards what each one of those care sessions are, but I think as you looked at them, you would see, there's natural topics where that conversation is invited.
Mm-hmm. Well, a related question then is, what kind of training in group dynamics do your providers who are running the course have?
Excellent question. So there are 2 providers in the care session, and that's very important. So one is an OBGYN or a nurse midwife who is trained, but then also a second who is trained in group facilitation. Okay. We do not want the model to be a didactic. It should not feel that you're coming into a class. Literally, that the chairs in that session are in a circular format, and the providers sit at level with the participants, which creates an interest, a better facilitation. So, but yes, there's always somebody in the room. We don't expect all practice providers to go through that group significant group dynamic training, but there is somebody in the room who has, and it's a significant part of the care model training as well. So, do they need to have extensive study in that? No. Is it a part of our training program? Yes. And we ensure that a second person in the room, that is their strong suit.
Mm-hmm. One last point: seeing you are involving low-income women, I would suggest to you that in reaching out to your various potential partners, you include community health centers in that group.
We have, and it is one of our, one of the, in Detroit, as we're going out with a pilot later this year, one of them is a community health center, and what's great about that model is, we're very excited, is there will be community health workers who are not only engaging as a part of the engagement process, but that same community health worker will be in the care model and being a part of the delivery. So that is something we're excited to see how that works.
Thank you.
Good morning, Rose Stith, Singleton, City of Richmond, Virginia. I loved your videos. Wish we had time to see them all. But wanted to know, do you have one that covers breastfeeding for women who go into preterm labor and deliver? Because that's such a stressful time for any woman, low-income woman, middle-class woman, and they may feel that they cannot breastfeed or pump at that time, and because they don't think that the milk is full term, but we know that when you deliver, the milk is at the right composition for the baby at that time. And that may be something you want to consider. Have you all have one that specifically addresses
We don't have a
that?
video that addresses that, but we have lots of plans to create more videos. We do have a lot of content, and one of the things that's great about the website, and I can show you some of the content that we do have, it's not all of it on breastfeeding, which does address some of those pieces. The other great thing about it is that each practice can upload their own content to the website, which then is accessible to those women in that community. So when you think about nutrition, we're not, and somebody would want to upload recipes that are culturally appropriate for that group. The practice can do that. So that is another great. We believe that website will become a collection of really great resources, as well as the ones that we have developed. So to answer, we have some, and I can show you what some of those look like. Not as much as we probably need to keep developing, and we believe in a continual development model with feedback from the practices. And then third, there is the opportunity for specific information for each practice where they can also upload that so that their patients can have access to that information.
Well, I would like to put a plug in to do one for that, particularly for low-income women who have a high percentage of preterm births, and even if they have been thinking about breastfeeding, the trauma of going into preterm labor and delivering will throw the breastfeeding out in the bath with the water. So,
and what I think content is important, and I agree, and it's on the list. I think that the richest of what I've seen is the support and the dialogue that happens in session 3 and then also before birth. That's really that community of people encouraging and supporting. Right. So thank you.
Good morning, Rochelle Charles from Virginia Commonwealth University. Excellent presentation. I had a question specifically about the utility of the videos. Because I think in your presentation you had said that the videos could be used in the clinical setting. One, have you guys documented the use of the actual video in the clinical setting, and then the utility of that piece? And then the third part, well, I'll throw you all the questions at one time. Okay. So then the third part of it is, but it's all about just the use of the technology in the setting. So then the third question is, particularly the one on sexual health, because that just sparked a question for me for another project, but whether the utility of viewing that and how that's used to spark other referrals to other providers that's outside of the actual centering model.
Yeah, so let's start with technology and the use of that. So there's always the concept, and then there's the practical application. So we believe, as just a principle, that the technology is a key differentiator of this model, and now we've watched the uses of it and the usage of it both from a practice perspective and the women perspective. So we have and it's been spotty, some high use and some lower use. And so one of the things that we're now looking at with a national partner is how do we better embed that so that it is a consistent, that we don't have wide variance in use. So one of those is moving even into mobile apps and others. So that is on the development roadmap, so that people can access everything via smartphone. You can access it, it's just not an app. So it's mobile enabled, not an app, which matters. And then so the second piece of that is there's also at a practice, part of the challenge is, do we have Wi-Fi in that part of the hospital? And so can I access the video? And so part of the setup is addressing that before a practice starts, not finding or being surprised that that room where the group is being led doesn't have Wi-Fi access and therefore can't access the website and promote it. So we believe that in the right that it should be used in the care session, so it models it and then brings it and then establish it with patients. Now, 100% of patients have used the website because not necessarily when they go home, because that is where they log their weight, that is where they log their own height, and so they are accessing it in the care session each time. So 100%, and then the question is, are they accessing the videos, are they accessing all the other ancillary pieces, and that is what's spotty. So 100% use it. It is where the data is tracked, and then as you use all the additional features, we want to grow that.
And then the final question, just from a recruitment standpoint, because I think the first video was more on recruitment. Mm-hmm. So do you find that your recruitment is more heavily based on using the technology or that video, or more one-to-one
we believe
recruitment?
Both. So our hope, and is we've been successful in other models, is that a community health worker can have an iPad and is working in the community and talking about this model of care as one avenue. And so I believe that it's the blending. I don't believe, but we also have seen and had success. We worked with Comcast on to recruit for the virtual version of the DPP, and we filled the study in 2 weeks. Wow. And so, with public service announcements. So in this next round, we will be doing more public service announcements combined with the human touch to really create awareness in the community setting.
Thank you.
Yeah.
So really exciting to see this, and to see the technology wedded with the I still think of it as the centering concept, but the group prenatal care concept. I'm curious, when we've done group care in North Carolina in rural areas, there's a real challenge with transportation. Mm-hmm. And moms want to do it, but they rely on someone else for a car that breaks down or doesn't have gas or doesn't work, and so nobody comes. Mm-hmm. And I'm wondering how you all are planning to tackle that as you roll out to places that don't have public transit.
That is a challenge across all of healthcare, and I think it's magnified in prenatal care because there's so many sessions. So we have a lot of, we're not moving in this direction yet, but one of the things that we've seen in rural health is the power of virtual models, and how that can reduce that need for travel, et cetera. So we haven't, we're at a straw man stage at this point. So first is to get the study results out. Then is to ensure that within practices we can continue to sustain it and that it's a sustainable, low-cost model, that it doesn't require thousands and thousands of dollars to continue, and then we know and recognize that the transportation issues are a part of this, and there are many examples within United Healthcare on how they're addressing that, and I think part of that is collaboration with the payers on services that they have, because they have a vested interest as well in ensuring that patients get to prenatal care. So next, as we start to work across all of the payers and collaborating on this type, is we tackle some of the transportation issues and others, child care too.
Yeah.
Great. 2 questions. With regards to the National Diabetes Prevention Program, which I understand that your organization has co-led the effort with the CDC. Mm-hmm. I have tried to get your administrators to come to Mississippi with that program, and I've called various places, and I've been told, frankly, that the YMCA is not offering it in Mississippi, which is true. Nowhere in Mississippi is the YMCA offering that program. I understand that you have an exclusive online course, and I would like to know what it would take for you all to serve your members in Mississippi.
Well, you have come to the right person. Let's talk afterwards, because we were the original especially on the virtual. Mm-hmm. And so, first of all, my apologies that you haven't received a response, and I can help with that. And then I think we can look at the state of Mississippi, and it's too bad that that the Y is not able to service it in Mississippi. So let's talk, because there are virtual models, and there are that are highly effective and just as effective from an outcomes perspective, and we can talk.
My second question regards MCH. We are in the process of developing a very similar program. I think ours may be more comprehensive, more grassroots, but I'll get into that later. So my question is, do you have any plans of expanding your program to Mississippi? Is it one of those 4 states?
This program, Mississippi is not one of the first 4 states, and we're working with another national partner, but our goal, and we won't stop until this is at national scale.
Okay. So I'll talk to you later.
Great.
Can we limit to 1 question per person? We've got quite a line still forming.
Thank you so much for the great presentation. I'm Saba Masha from Virginia Commonwealth University, and I'm working with about 5 sites in Virginia that provide centering pregnancy as part of the Strong Start funded project, which is an excellent project. And when I learned about your program, it's really wonderful, and I'm really appreciative of the work that you're doing. But I thought I could learn a lot more from you in terms of some of the challenges that we are facing currently. When you go from grant to grant, whether federal or foundation and industry funding that we've been doing, and our smaller sites, particularly like the health departments, the federally qualified health centers, they couldn't maintain the training needs that they have and the turnover of providers that they have. Secondly, the other big issue in terms of sustaining is really engaging physicians. That's also another major challenge that we're having. The third issue is also mixing high-risk patients with low-risk patients because of their needs, and we've seen some patients fall into crack. And then the fourth thing is that in terms of sustaining the program, working with Medicaid and other payers to pay the amount needed. We have one clinic that had to shut down because they couldn't get reimbursed for all of the services that they have, and physicians feel like, I can't stay 2 hours or 90 minutes in that group and not be able to see 15 patients in that period of time. So my question is loaded because it's one question, but anyways, anything you could share would be great, and if you can't say much, I can talk to you later. But I thought people would benefit from it.
Sounds like you guys need to have a bigger conversation.
Well, let me bring all of those components back to a single topic, which is sustainability. So right now, we are working on those sustainability elements. So whether that be costs for training, costs for books, costs for practices to set up space, it becomes, if you don't have enough volume within each group, it becomes costly. So it's all of those sustainability pieces. So here's what we know. We know that group prenatal care is better care and it produces better outcomes. The question remains on scalability. How do you make it practical? How do you make it accessible so that it doesn't have a negative financial impact on the practice, because that will just stop things in its track, and that it is the right type of care, and how do we actually move towards the direction of incenting it. So the first thing we have to do is we have to remove those barriers of costs, and that's what we're focused on with another national nonprofit, and that's what we're building right now. So the implementation and year 1, year 2 sustainability, and what that support plan looks like, what the training looks like. It's automating a lot of training. It's making it virtually accessible so you don't have to leave your practice to go to training. So we're doing a lot of those pieces, and then we'll continue, right, with every problem we solve, we'll get to the next problem, and we'll continue to solve those pieces. And so I think it's really important. We're moving slow in the beginning, so that when we are nationally scaled, that we don't have massive sustainability issues. So we're going slow now to build the tools, so that then, in essence, a hockey stick of expansion, so that we can get to states, lots of states quickly. So the infrastructure is being built for that, and we're testing out that additional infrastructure now in Tennessee and in Detroit.
Thank you.
Yep.
Please. Make sure you identify yourself and where you're from.
Sure. I'm Yvette Piovanetti. I'm a pediatrician from Puerto Rico. And you answered some of my questions. Excellent presentation and beautiful centered pregnancy. But as a physician, I was just concerned exactly what you mentioned, that if you have the group prenatal care, is the mother, you said she would check in prior to the visit with her weight and height, or during the visit, and will the physician, how's this combination between the physician connections, looking at the red flag, so we don't lose the patient who's gaining excessive weight or losing excessive weight? Do we take them separately at the same time, and so it will be more than 2 hours?
Yes. So no. So here's what happens. a woman walks in, and so in the beginning of each care session, the physician spends time behind a private screen with the individual patient.
Before this group session or after the group session?
It's a part of the group session. And so the way that it works and the way that we've done this is that women come in and they take their own height, their own weight, their own blood pressure, and they enter it into the technology in the system, so that when that woman goes and has their individual meeting with a physician, that information is there, and she can validate that information is correct. Now, the women who are during this beginning part, there's also activities that the second facilitator are facilitating. So it is not separate. It is a part of the group care model. The other piece is if there is something, an indicator of high risk, it does not exclude them from coming back for high risk tests, etc. Anything that you would do in normal care, they can come back for specific issues that might be seen.
So it's not built into your system, like it would be a red flag if you have high blood pressure. Would that signal in the web couldn't go back to the physician saying this person has the high blood pressure, needs to be seen immediately or something like that?
The patient takes their blood pressure and immediately follows up with the physician. So the physician is looking. Yes. So the reason they take their own weight and their own blood pressure is because we think that active participation in health is a good thing, and it's important to know your numbers. That doesn't mean then those numbers are discussed one-on-one with the physician, and then they go to the large group setting. So if there's something, for instance, if they can't find the heartbeat of the baby, or something, that is the belly check and all of that, the fundal height, all of that is being done behind the private screen, and that is why there are two facilitators in the group, so that if a physician needs to or a midwife needs to step out or there's an emergency, the group continues.
And how about family intervention? Are they allowed to come to this group prenatal visits?
Yes.
That's very important for us.
Yes. So this model includes, now there's each practice is different. I would say 90% of practices invite the spouse or the partner or the
mother or the sister.
Yes, and that is something that the practice, sometimes it's size of room. Our philosophy and our belief is that there should be a partner there with the expecting mom.
Because you had mentioned the midwife and the doula. Thank you.
Discussion so we can move on to other things. But thank you so much, and we'll have time at lunch again. I think we've got time, and if you're interested in speaking to her, we can do that. But thank you for your time and this exciting presentation.